So for resectable tumor, two options. If there is adequate hepatic reserve, here you can see we go for resection, and if there is inadequate hepatic reserve, we go for liver transplantation. Simple. Hi guys, hope you are safe and healthy. This is Dr. Pritesh Singh, author of Surgery Sense, NEET Sense, Sense, INI-CET Sense, Quick Review of Surgery, and PrepLadder Surgery Faculty. We are going to discuss the surgery questions of INI-CET November 2021. In comparison to July session, this paper was a bit tough. Majority of surgery questions were clinical. Okay, so let's start the discussion. See the first question. A patient underwent mastectomy and given drain was kept under the flap and the flap was closed. What type of drain is this? So you have seen a patient of mastectomy, or you have seen patients of modified radical mastectomy in the ward, and you have seen such kind of drain. This is known as Romovac drain. How we use this Romovac drain? Here you can see this is the tubing in the drain, and this is the reservoir bag. So this is reservoir bag. Okay, how we use this drain? First we have to detach the reservoir bag from the tubings. We have to apply the suction, and after applying the suction, means we are pressing the reservoir bag, and then we are going to connect it with the tubings. So suction is created. What happens here? Suction is created, and with the help of suction it is going to work. So any drain which utilizes suction to work, that is known as closed drain. Closed drain. What are the other types of drain? It can be open, semi-open, and closed. So this is a closed drain because here what is being utilized? Suction is being utilized to work. See what are the types of drains. There are three types of drain. First is open drain. You have seen patient of breast abscess, and in those patients you see we perform incision and drainage. Right? After that, we give one counter incision also. So there is one incision and we give counter incision, and after that we insert what? Corrugated drain, or sometimes plastic sheet. So you insert a corrugated drain, and how this drain is going to work? This is going to work with the help of gravity. So open drain is going to utilize the principle of gravity. Second type is known as semi-open. In semi-open drain, we apply the principle of capillary. So semi-open drain works on the principle of capillary effect. And the third, which we saw, that is closed drain, and this closed drain utilizes suction to work. There are two closed drains which are commonly asked in exams, and we use these drains in the ward also. There are two commonly used closed drains. One is Jackson-Pratt drain and second was Romovac, which we discussed. So this is JP drain, also known as Jackson-Pratt drain. In this you can see this is the emptying port and this is the emptying cap. This is collection reservoir. So what we do, we are going to open the emptying cap. After opening the emptying cap, you are going to apply the suction, means press the reservoir bag so that suction is created. After that, you close the cap. And when the suction is created, can you see it is going to suck the fluid, suck the blood or serous material. So this is Jackson-Pratt drain and that was Romovac drain. Both of these are closed drain. Why? Because these drains require suction to work. So if we see the question again, this is Romovac drain. What kind of drain is this? This is closed drain. So correct answer for question number 1 is D. See second question. During surgery of carcinoma breast, frozen section was done. This procedure will be useful for all except. So why we perform the frozen section? For rapid microscopic analysis of specimen. If you have seen frozen section. Usually in cases of breast cancer, when we perform sentinel lymph node biopsy, we send the specimen. So frozen section in CA breast is mainly done for sentinel lymph node biopsy. Second, whenever we are removing the tumor or the specimen and we are not sure whether the margin is positive or not, then we send the frozen section. So it is used for margin positivity. It is used for sentinel lymph node biopsy. Now, done in all cases for immediate diagnosis. See, whenever we are taking any patient of breast cancer for surgery, before surgery, the diagnosis should be confirmed on true cut biopsy or core cut biopsy. So always the histopathological diagnosis was already confirmed by true cut or core cut biopsy. That's why for immediate diagnosis of the tumor, it is not done in all the cases. So this is incorrect. D is to identify the metastatic lesion. Let's discuss it with one example. Imagine a patient is having carcinoma lung, okay, and you are planning lobectomy. You planned the lobectomy. The patient is inpatient, surgery was done. Now the lung is there, and there is another nodule which was missed on radiological investigation. So this could be some metastatic lesion or this could be a primary tumor. So whenever you are not sure that the nodule is a primary tumor or a metastatic lesion, intraoperatively you can send the frozen section biopsy and you can confirm it. Clear? So it is also used to identify the metastatic lesion. So A, B and D are correct. C is incorrect. Why? Because diagnosis was already done with true cut biopsy or core cut biopsy. So frozen section is useful in A, B, D, but it is not useful in C. So C is the correct answer. See the third question. It's a repeat question. This question was asked in AIMS November 2017. In a case of carcinoma breast with HER2 new immunohistochemistry staining, which of the following score needs further FISH study? So if you see the scoring of HER2 new immunohistochemistry assay, if it is 3 plus, it is considered positive. If it is 0 to 1 plus, it is considered negative. And whenever it is 2 plus, it means it is equivocal. So if 2 plus is equivocal, for 2 plus you need another analysis system to confirm. So that's why if it is 2 plus, we need FISH to confirm the HER2 new status. Clear? So for 0 to 1 plus, it is negative. If it is 3 plus, it is positive. 2 plus is equivocal. And for this patient, what you need? You need FISH for confirmation of diagnosis. So here we perform the FISH. Right? So which score needs further FISH study? If the score is 2 plus, so correct answer for this question is C. Now see the question number 4. A 30-year-old female presented with complaints of what? Palpitation. What else? Feeling febrile all the time. There is a midline neck swelling. So there is swelling of thyroid with palpitation. On examination, diffusely enlarged thyroid is felt. Lower border of swelling is seen moving with deglutition. Okay, so it is actually diffuse toxic goiter. Another finding, there was exophthalmos. Right? So palpitation means signs and symptoms of hyperthyroidism are there. Second, patient is having diffuse thyroid swelling, that is diffuse toxic goiter, exophthalmos. So all of these are suggestive of what? Graves' disease. All these findings are suggestive of Graves' disease. And you know, in patients of Graves' disease, if you perform thyroid function test and there is suppressed TSH, obviously there will be suppressed TSH, there is increased T3, increased T4. So if there is suppressed TSH with eye signs, diagnosis is confirmed. Second, if patient is not having eye signs, patient is having diffuse thyroid enlargement, in those cases we go for radioactive iodine scan. And you know, in Graves' disease, the thyroid gland is hyperactive and hypervascular. So what will happen? There will be increased radioactive iodine uptake. Right? You know, Graves' disease is an autoimmune disorder. And in this case, there are autoantibodies against which receptor? There are autoantibodies against TSH receptor. These are stimulatory antibodies. Because of that, there is increased secretion of what? T3 and T4. So if the patient is having stimulatory antibody against TSH receptor, this is also diagnostic. There is another question asked in relation to Graves, that do you need ultrasound neck in patients of Graves disease? Yes. When you need ultrasound neck, whenever we are looking for the clinical landmarks, when we are planning to take this patient for surgery. So whenever the patient is planned for surgery and you want to assess the clinical landmarks, for that you require what? Ultrasound neck. What is the role of FNAC in Graves disease? FNAC is generally not done in Graves disease. FNAC is not required. Why? Diagnosis can easily be made by the TFT and presence of high signs. Some students were asking this question in one of the discussion, that sir, FNAC is contraindicated in Graves disease? No, FNAC is not contraindicated. Let me tell you, in thyroid swelling, there are only two contraindications for FNAC. One, if the patient is having some kind of bleeding diathesis or bleeding disorder, because if patient is having bleeding disorder, you are going to perform FNAC, it will lead to what? Hematoma. And second, if the patient is not cooperative. So there are only two contraindications for FNAC in thyroid swelling. One, bleeding diathesis. One is bleeding diathesis. And the second is if patient is uncooperative. Uncooperative patient. So frankly speaking, Graves disease per se is not a contraindication for FNAC. So see the language of question. What are the essential investigations to be done? One by one. First investigation which should be done, that is thyroid function test. Clear? We will go for thyroid scan, anti-thyroid antibodies, these are diagnostic, and ultrasound neck, it is used to assess the surgical landmarks or clinical landmarks when you are planning to take this patient for surgery. So apart from FNAC, rest all investigations are essential in the patient of Graves disease. Clear? So 1, 3, 4 and 5, these are correct. Clear? So which one is the correct answer for this question? The correct answer for this question is B, 1, 3, 4, 5. Now let's see the literature what's written in the surgery books. This is Schwartz, and in this you can see what is written. Diagnosis of hyperthyroidism is made by suppressed TSH with or without elevated free T4 or T3 level. If eye signs are present, other tests are generally not needed. So diagnosis will be confirmed. Second situation, if a patient is having absence of eye findings, in those cases we go for thyroid scan. And whenever you perform thyroid scan, there will be increased radioactive iodine uptake. So increased radioactive iodine uptake with diffusely enlarged gland confirm the diagnosis of Graves. Simple. Now see what is written related to antibodies. If there is thyroid stimulatory antibodies, means autoantibodies which are stimulating antibodies against TSH receptor, these are diagnostic of Graves. Related to ultrasound, the role of ultrasound, what is written in subistan? So it is written that ultrasound or CT scan of neck can be performed to evaluate clinical landmarks if needed for surgical planning. Got it? So question again, see the question again. We perform thyroid function test, we perform thyroid scan, anti-thyroid antibodies and ultrasound neck. These are the essential investigations in patients of Graves disease. Question number 5. Inferior thyroid artery supplies to. So you know the name is thyroid artery. So obviously it supplies thyroid. Inferior thyroid gives the branches to parathyroid also. That's why you must be knowing whenever we perform the surgery, inferior thyroid as well as superior thyroid artery both should be ligated close to thyroid. Why we ligate inferior thyroid artery close to thyroid? Because the parathyroid supply comes from a branch of inferior thyroid artery which is an end artery. Clear? So thyroid, parathyroid both are supplied by inferior thyroid artery, and you know The cervical part of esophagus also receives its blood supply from inferior thyroid artery. So in this image you can see this is the inferior thyroid artery, and here you can see it is supplying thyroid as well as what, parathyroid gland, and it also supplies what, cervical part of esophagus. So it supplies esophagus, parathyroid, thyroid. So 1, 2, 3 are correct. So correct answer for this question is B. Now see this question. This is based on the latest updates related to management of HCC. Okay. So first, which of the following statement is correct regarding the HCC demographics and treatment? First statement is global incidence of HCC is rising. Yes, it's correct. NASH, so non-alcoholic steatohepatitis and non-alcoholic fatty liver disease, these are the risk factors. Yes, both of these are the risk factors. Both of these are going to lead to cirrhosis, and you know, in patients of cirrhosis there is chronic inflammation going on in the liver and it can progress to HCC. So both of these are the risk factors. Lenvatinib oblique ipilimumab is used for tumor size less than 3.5 centimeter. Some students were telling that sir, ipilimumab was also given. No, it was lenvatinib. So lenvatinib is used for tumor size less than 3.5 centimeter. Let me tell you, initially the first line agent for advanced and metastatic HCC was sorafenib. Nowadays, we are also giving lenvatinib, and this is given for advanced and metastatic HCC. Given for advanced and metastatic HCC. It is not given for a tumor which is less than 3.5 centimeter because it is resectable tumor. And TACE, what is the full form? Trans-arterial chemoembolization is done for multinodular tumor. So let me explain it. Whenever a patient is having more than 3 tumors, generally it is unresectable. So this patient is having multinodular tumor. So if a patient is having unresectable HCC, for palliation we go for trans-arterial chemoembolization TACE. So if you see all 4 options, 1 is correct, 2 is correct, 3 is incorrect, 4 is correct. First see the literature, then we will discuss it again. See the Harrison. It is written that there is growing incidence of HCC worldwide. So first option, it is correct. See this statement, non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Both of these can progress to cirrhosis and hepatocellular carcinoma. So obviously both of these are the risk factors for HCC. The third option was related to the management. Okay, it's very easy to understand. Have a look. Imagine this is the patient and this patient is having hepatocellular carcinoma. Hepatocellular carcinoma can be resectable or unresectable. If it is resectable, we have 2 options. What? We can go for resection. If it is resectable, you resect it. But second situation, if you are planning the resection, but because of cirrhosis, the liver is already so much damaged that there is no adequate hepatic reserve. So if a patient is having resectable tumor with adequate hepatic reserve, we go for resection. If a patient is having resectable tumor but there is inadequate hepatic reserve, means condition of liver is not good, in that case what we go for? Liver transplantation. So for resectable tumor, 2 options. If there is adequate hepatic reserve, here you can see we go for resection, and if there is inadequate hepatic reserve, we go for liver transplantation. Simple. Now the second situation, patient is having unresectable tumor when the number of tumors are more than 3. Clear? In this case, we go for palliation. So if a patient is having multinodular tumor, what is one of the option which is having survival advantage? The type of palliation having survival advantage. So it is trans-arterial chemoembolization. It is having survival advantage, used for multinodular tumors, used in HCC which is unresectable. Third situation, imagine at the time of presentation patient is already having advanced and metastatic disease. And if patient is having metastatic disease, in that case, what's the first line agent? Here you can see sorafenib, and the second option lenvatinib. So first line is sorafenib, and what else? Lenvatinib. Lenvatinib. These are given for advanced and metastatic HCC. The second line agent is regorafenib. Here you can see. This is regorafenib. What is the other use of regorafenib? You know, it is also used in GIST. The first line agent in GIST is imatinib mesylate. Second line is sunitinib. Third line is regorafenib. And the another agent which is used, that is carbonzatinib. So I'm repeating. First line agent in advanced and metastatic HCC, sorafenib. Second agent, lenvatinib. And the second line agents are regorafenib and carbonzatinib. Got it? So this is how we manage patients of HCC. Now see the TACE, trans-arterial chemoembolization. So it works on which principle? This is hepatocellular carcinoma. And you know, hepatocellular carcinoma is exclusively supplied by branches of hepatic artery. Simple. Exclusively supplied by branches of hepatic artery. So whenever you are going for trans-arterial chemoembolization, here you can see I'm inserting the catheter, and this catheter is finally going into which artery? Branch of hepatic artery. And via this you are going to give what? The chemotherapy agent, anti-cancer agent. Which anti-cancer agents are used? How to remember? Mnemonic is LCD. LCD means in the liver we can give either C or D. C means cisplatin and D means doxorubicin. What we give? Cisplatin or doxorubicin. How this cisplatin or doxorubicin is given? With an emulsion of lipiodol. So we are going to create the emulsion with lipiodol and we are going to inject so that this chemotherapy, can you see here? This chemotherapy is directly delivered to the tumor. And after this delivery, what you do? You are going to obstruct the feeding artery with sponge particles. So here first the chemotherapy is delivered and then you are going to cut off the vascular supply with the help of sponge particles. What's the name? Trans-arterial chemoembolization. So you are giving chemotherapy. So this is the kind of palliation which is having survival advantage. TACE. And for which tumors it is used? You can see here. For primary treatment of unresectable HCC. Unresectable HCC agents, you give cisplatin or doxorubicin, and for obstruction of feeding artery, we inject sponge particles. So all four options are clear now. So first option, global incidence is rising. Yes. NASH and NAFLD are the risk factors. Yes. Lenvatinib is used for tumor size less than 3.5 cm. No, it is used for advanced and metastatic disease. TACE is done for multinodular tumor. Yes, it's correct. So 1, 2 and 4 are correct. So correct answer for this question is A. Now see the question number 7. Though the question is big, but question is very easy. A patient presented to emergency with abdominal pain, jaundice and fever. You tell me what's the name of this triad. Pain, jaundice, fever. You know, this is Charcot's triad. This is Charcot's triad. Cholangitis was suspected. Which of the following are the components of Reynolds Pentad? So patient of cholangitis are having pain, jaundice, fever. This is the classical triad known as Charcot's triad. In such patients, if there is delay in treatment or if there is inadequate treatment, it can progress to what? Reynolds Pentad. So here you can see. So whenever in the patients of cholangitis there is pain, fever, jaundice, there is delay in the treatment, then patient is going to develop shock and mental status changes or mental obtundation. So when such patients are going to develop shock or shock and mental obtundation, this is known as Reynolds Pentad. So what are the components? Pain, jaundice, fever, shock or hypotension, mental obtundation. So see the components. Along with abdominal pain, what are the components of Reynolds Pentad? So there is jaundice, melena is not there, mental obtundation, there is hypotension or shock, there is fever, there is no hematemesis. So 1 is correct, 3 is correct, 4 is correct, 5 is correct. So which of the following is correct answer? The correct answer for this question is B. See question number 8. Patient presented to hospital with jaundice. Patient is having jaundice. Ultrasound and CECT was done. No stone in the gallbladder. So what is the cause? Intrahepatic biliary radical dilatation is there. IHBR is dilated. Intrahepatic biliary radical dilatation. Okay, it's very easy to understand. Have a look. This is the liver. This is the gallbladder. This is the bile duct. This is the intrahepatic biliary radicals. And whenever only intrahepatic biliary radicals are dilated, it means there must be some obstruction where into the extrahepatic part of bile duct, right? So most probably the obstruction is somewhere here. Clear? And for accurate assessment of level of obstruction of CBD, what is the investigation of choice? It is MRCP. So in such patients, you have to rule out the CBD obstruction. You have to look for the CBD obstruction. What's the level? We go for MRCP. And you know, MRCP is T2 phase of MRI. It is T2 phase of MRI. So what is the correct answer? The correct answer for this question is A, that is MRI. We don't go for PET-CT. PET-CT is generally done in the patients who are having metastasis. Yes, after that there is recurrence also. So for recurrence or metastasis, PTC is also not done. Both PTC and ERCPs, these are both diagnostic and therapeutic. So until and unless you don't have confirmed diagnosis, we generally don't go for PTC or ERCP directly. So correct answer for this question is MRCP. It's not given in the option, so we will mark what? A, that is MRI. Now see the question number 9. This is the image based question which is asked almost every year in each and every paper. Every year in each and every paper, see the question. 30 years old patient was hit by a bull. Later presented with complaint of abdominal pain for 3 days. So first finding, patient is having abdominal pain and obstipation, non-passage of feces and flatus for 2 days. There is nausea and vomiting. Patient was initially stabilized but now presented with increased pain, and on examination, abdomen was rigid. Radiograph was performed as shown below. What could be the most likely cause of this condition? So can you see here? You can see the free air under the right dome of diaphragm. So what is this? This is pneumoperitoneum. There is free air. It means this patient is having what? Perforation peritonitis. Okay. So after trauma, there is perforation peritonitis. That's why what are the findings seen in patients of perforation peritonitis? Pain all over abdomen, tenderness all over abdomen, there is tachycardia, there is obstipation. And if you perform the examination, what? The abdomen is rigid. So there is guarding and rigidity. So many findings are there. Straight away you can make the diagnosis on the basis of this X-ray. So this patient is having what? Hollow viscous perforation. This is a patient of perforation peritonitis. Now see the question number 10. Which of the following is true about colon cancer? First option, colon cancer can be prevented by metformin. What is the role of this metformin nowadays in malignancies? Metformin is having chemopreventive role for some of the cancers, and one of the cancers is colorectal cancer. So in colorectal cancer, the metformin is having chemopreventive role. It means the diabetic patients who are taking metformin for longer duration, it is found that there is decreased incidence of colorectal cancer. So it can be prevented by metformin. It is correct. Right and left colon cancer can have different presentation. Now see what kind of presentation is there. In this diagram here you can see this patient is having right colonic malignancy, And can you see the appearance of this tumor? This tumor is ulceroproliferative, also known as fungating. So on the right side, bleeding is more common. Why? Because tumor is ulceroproliferative or fungating. The bleeding can be in the form of occult bleeding leading to anemia. It can lead to fresh bleeding, that is hematochezia. It can lead to melena. Or sometimes in advanced cases, patient is having right eye lymphosa mass. So on right side, bleeding is more common. Now see this patient. This patient is having annular or stenosing growth. Okay, so this is the colon. This kind of growth is there. This is annular or stenosing. What is the difference between right and left colon? That there is progressive narrowing of colon from right to left side. So obviously the widest part of colon is cecum, narrowest part of colon is sigmoid. Second, the growth is annular or stenosing, and third, the fecal matter is solid on the left side. Clear? So narrow caliber, solid fecal matter, annular or stenosing growth. Because of all these, what is more common on the left side? Obstruction. So bleeding, it is more common on right side. Obstruction, it is more common on left side. Now see the question again. So this option is also correct. Colon cancer can be hereditary. Yes, yes. How much? On an average, 2 to 5% patients are hereditary. 2% to 5% colon cancer is hereditary. And you know, one is FAP, commonly asked, second is HNPCC. Both of the FAP, familial adenomatous polyposis, HNPCC, hereditary non-polyposis colon cancer. Both of these are autosomal dominant. And what kind of polyps are there? Adenomatous. So colon cancer can be hereditary. This is also correct. And we discussed many times in the classes, in the videos, what is the most common site of metastasis from colorectal cancer? Not only colorectal cancer, any malignancy from esophagus till rectum having hematogenous spread, most common site of metastasis is liver. It is liver. So 4 is also correct. So 1, 2, 3, 4, all of these are correct. So correct answer for this question is A. Now see the question number 11. Appendectomy was performed in the patient of appendicitis. Surgeon first used gridiron incision, which was later converted to Rutherford Morrison incision. Which of the following does the surgeon needs to cut further? Okay, so first see what are the various incisions given in appendicitis for appendectomy. You know, this is umbilicus and this is anterior superior iliac spine. Whenever we join umbilicus to anterior superior iliac spine, this line is known as spino-umbilical line. On this line, at the junction of lateral 1/3 and medial 2/3, this point is known as McBurney's point. So what's the name of this point? This is McBurney's point. You know, this McBurney's point corresponds to the base of appendix. It corresponds to what? Base of appendix. And this is the most tender point in acute appendicitis. So two important points. McBurney's point corresponds to the base of appendix. It is the most tender point in patients of acute appendicitis. See the incision. Whenever I give incision centered at McBurney's point perpendicular to spino-umbilical line, this is known as McBurney's incision. It is also known as gridiron incision. It is also known as MacArthur incision. What are the names? McBurney's incision, gridiron incision, MacArthur incision. And this incision is muscle splitting. It is not muscle cutting, muscle splitting incision. There is another muscle splitting incision. Imagine this is clavicle, midpoint of clavicle, and you are going to join this midpoint of clavicle to midpoint of inguinal ligament. So this is the line which joins midpoint of clavicle to midpoint of inguinal ligament. On this line, 2 centimeter below umbilicus, I give a transverse incision along the skin crease. And what's the name of this incision? This is known as Lange incision. What are the other names of this Lange incision? This is also known as modified McBurney's incision, also known as Rocky Davis incision, Rocky Davis, and this is also known as bikini incision. Why? Because these incisions are, yes, this incision is cosmetically better. So Lange incision, it is given on the line joining midpoint of clavicle to the midpoint of inguinal ligament, 2 centimeter below umbilicus, transversely along the skin crease. What are the other names? Modified McBurney's, also known as Rocky Davis, also known as bikini incision. So both McBurney's incision as well as Lange's incision are muscle splitting. Which one is cosmetically better? Preferred nowadays? Lange incision. Now imagine a situation. This is the cecum and this is the appendix. An appendix is behind the cecum. So what kind of appendicitis? This is retrocecal. So sometimes it's difficult to localize the appendix when it is retrocecal. In this case, I have to divide the conjoint tendon. I have to cut the external oblique. And I have to extend the incision upwards and laterally. So when you extend the incision upwards and laterally, cut conjoint tendon and external oblique, this is known as what? Rutherford-Morrison incision. So Rutherford-Morrison incision, this is muscle cutting incision. What kind of incision? This is muscle cutting, and it is going to divide external oblique and conjoint tendon, and you know that conjoint tendon is found by internal oblique and transversus abdominis. So we have to cut external oblique, internal oblique and transversus abdominis, not the rectus abdominis. So correct answer is 1, 2, 3. So correct option is option A. This is Rutherford-Morrison incision, which is muscle cutting incision. It is going to cut external oblique, internal oblique and transversus abdominis, especially for the patients in whom appendix is not visualized by McBurney's incision. So correct answer for this question is A. It's an easy question and repeat question. You know, there is massive splenomegaly seen in CML, Hodgkin's lymphoma and hairy cell leukemia. In Hodgkin's lymphoma, CML and hairy cell leukemia, there is massive splenomegaly. But splenomegaly is not seen in the patients of aplastic anemia. So there is no splenomegaly in aplastic anemia. So correct answer for this question is A, that splenomegaly is not seen in the patients of aplastic anemia. See question number 13. It's an indirect repeat because similar questions were asked many times in the exams. Patient presented to the hospital with hematuria. Urine microscopic examination reveals high-grade transitional cell carcinoma. So there is high-grade bladder tumor. CT scan shows what's the size of mass? 2 into 2 centimeter mass in the bladder. What's the management? So whenever the patient is having a bladder tumor which is not very advanced, there is no involvement of muscle layer. In such patients, we perform cystoscopy, and what we do during cystoscopy, we are going to resect the tumor. So this is transurethral resection of tumor. Since patient is having high-grade tumor, after tumor resection, we give intravesical chemotherapy. So how it's done? Here you can see how we perform the transurethral resection. Here you can see this is the cystoscope. First you are going to perform the cystoscopy. You found the tumor, and after that you are going to excise the tumor. So this is transurethral resection of bladder tumor, known as TURBT. Right? After that, if it is high grade, we give intravesical chemotherapy. Another situation, imagine if the tumor is involving the muscle layer, if there is involvement of muscle layer, in such patients we go for what? Radical cystectomy. So radical cystectomy is only done in the patients where there should be at least the involvement of muscle layer, means tumor is advanced. Third situation, whenever you are performing the MRI pelvis and you found that tumor appears unresectable, in those cases we are going to downstage the tumor. So how you are going to downstage the tumor? We give neoadjuvant systemic chemotherapy, not intravesical. We give neoadjuvant systemic chemotherapy. And what's the chemotherapy regimen which is given? It is MVAC. M means methotrexate, V means vinblastine, A means adriamycin, C means cisplatin. Methotrexate, vinblastine, adriamycin, cisplatin. So this is the systemic chemotherapy which is given. Clear? The patients in whom there is advanced malignancy, we want to downstage it. Clear? So this is the concept of management of bladder tumor. Now see the question again. So here there is 2 into 2 centimeter mass high grade tumor is there. So obviously we have to resect the tumor. Transurethral resection of bladder tumor. Will you go for radical cystectomy? No, because there should be involvement of muscle layer. Tumor should be advanced. Will you go for hemicystectomy with bladder reconstruction? No. And will you give neoadjuvant chemotherapy? No, because tumor is not advanced. So here, what's the correct answer? The correct answer for this question is A. Since it's a favorite topic of AIMS and INI-CET people, let's discuss what's the management of CA bladder. So if a patient is having TIS, that is also known as malignant cystitis, which is also known as malignant cystitis. In this case, we give intravesical BCG. And if a patient is having papillary tumor, that is also known as TA. It is single, low to moderate grade and non-recurrent. In that case, go for transurethral resection known as complete TUR. And if patient is having TA, that is large, multiple, high grade or recurrent, or patient is having T1 here, apart from complete TUR, we have to give what? Intravesical chemotherapy or immunotherapy. Radical cystectomy is done in patients who are having T2 to T4. The stage is T2 to T4. If the tumor appears advanced, appears unresectable, we downstage it. So sometimes we give neoadjuvant chemotherapy and then we plan radical cystectomy. Sometimes you perform radical cystectomy and you think that still some part of tumor is left in the pelvis. In those cases, what you give radiotherapy. Clear? So after surgery, we give radiotherapy also. And if the patient is having advanced metastatic tumor, or if there is metastasis, so here we give systemic chemotherapy. Regimen is MVAC, followed by surgery or palliation. So this is how we manage the patients of bladder tumor. See the question number 14. All are lower urinary tract symptoms. LUTs, lower urinary tract symptoms, except incontinence while intercourse, sudden urge to urinate. What's the name of this symptom? This is known as urgency. Incontinence while sleep. This is known as nocturnal enuresis. So generally, there is loss of urine during sleep, nocturnal enuresis. And check for leak by making the patient cough. So whenever patient is coughing, laughing, there is increased intra-abdominal pressure. Because of that, there is incontinence. Loss, there is passage of urine or incontinence. This is known as stress incontinence. This is known as stress incontinence. Clear? So urgency, nocturnal enuresis, stress incontinence, all these are included in LUTs, lower urinary tract symptom. Incontinence while intercourse, it's not included. So correct answer for this question is A. It is very easy to understand lower urinary tract symptoms. Imagine this is the bladder, this is the prostate, and this is the urethra. Clear? Okay. Generally in elderly patients, one of the common cause of bladder outlet obstruction, and what's that? It's the BPH. So imagine this patient is having BPH. Because of this BPH, what will happen? There is obstruction of urethra. So because of this obstruction, whatever the symptoms are there, those are known as obstructive symptoms. These obstructive symptoms are also known as what? Voiding LUTs. It is included in voiding lower urinary tract symptoms. So obstructive symptoms are voiding LUTs. Whenever there is obstruction, the bladder has to contract against the resistance. Because of that, what will happen? In the bladder muscle, there is detrusor muscle hypertrophy and detrusor muscle hyperplasia. This is responsible for irritative symptoms. Irritative symptoms. Clear? So this irritative symptoms, these are storage LUTs. Storage LUTs means lower urinary tract symptoms. So what are the irritative symptoms? You know, it is frequency, urgency, nocturia and urge incontinence. What happens in urge incontinence? There is urgency of passage of urine and then there is involuntary loss. So urgency followed by incontinence is known as urge incontinence. So in storage LUTs, that is also known as irritative symptoms. These are suggestive of what? Detrusor muscle hypertrophy. Detrusor muscle hyperplasia means overactive bladder. And what are the symptoms which are included in storage LUTs? Mnemonic is FUN. What is FUN? Frequency. This is urgency, nocturia, and these patients have urge incontinence. And because of obstruction, there is obstructive symptoms which is also known as voiding LUTs. So obviously in that there is hesitancy, reduced stream and straining. When the patient is going to pass the urine, after that if some symptom is there, that is post-micturational. So this patient is going to complain that there is incomplete voiding in such patients. There is incomplete evacuation of bladder, that is incomplete voiding, or after micturition there is dribbling of urine. This is known as post-micturition dribbling. Clear? So post-micturition dribbling. So let's quickly summarize. Irritative symptoms, also known as storage LUTs. Because of overactive bladder, there is frequency, urgency, nocturia, urge incontinence. Then there are voiding LUTs. It is because of bladder outlet obstruction. There is hesitancy, reduced stream, there is poor stream and there is straining. And after micturition, that is post-micturational symptoms. So these patients have incomplete voiding or post-micturational dribbling. There are certain terms which you are supposed to remember. What is urgency? It's a compelling desire to pass the urine. Clear? Urgency. And what is urge incontinence? Patient is having urgency and after that what happens? There is involuntary urinary leakage. So urgency followed by involuntary urinary leakage, that is urge incontinence. So urgency followed by incontinence. Stress incontinence, any patient in whom intra-abdominal pressure is going to increase and because of that there is involuntary urinary leakage, like patient is coughing, laughing or exercising, and then it leads to incontinence, stress incontinence. And sometimes when the patient is sleeping, what happens? These patients have retention of urine and there is overflow incontinence. So involuntary loss of urine during sleep, this is nocturnal enuresis, right? So if you see the question again, all are lower urinary tract symptoms except, so sudden urge to urinate, this is urgency, it is included. Incontinence while asleep, this is nocturnal enuresis. And check for leak by making the patient's cough because it is going to increase the intra-abdominal pressure. So it leads to stress incontinence. So what's the correct answer? Correct answer is incontinence while intercourse. It's not included in lower urinary tract symptoms. So correct answer is A. Question number 15. It's a repeat question. Most common cause of bladder outlet obstruction in male neonate. There is exclusively an abnormality of urethra seen in males and this is posterior urethral valve. What happens here? This is the patient. So in this patient, there is symmetric fold of urothelium. And if there is symmetric fold of urothelium, this is unidirectional. What is the location? The most common type is type 1 and it is located just distal to verumontanum. Just distal to verumontanum. This is the most common site, right? So this is posterior urethral valve, means urethral valve present in posterior urethra. Which part of urethra? Prostatic urethra. Exact location just distal to verumontanum. You can diagnose this condition during pregnancy also. So around 28 weeks of pregnancy, if you perform the ultrasound, here you can see distended and thickened bladder. So this is known as keyhole sign. Keyhole sign. By the way, how we make the diagnosis of bladder outlet obstruction caused by posterior urethral valve? So for posterior urethral valve, investigation of choices, MCU, and how we treat it, we perform endoscopic fulguration of valve. So this is actually transurethral ablation. Clear? So the most common cause of bladder outlet obstruction in male neonate, that is posterior urethral valve, and we discussed it is exclusively an abnormality of male urethra. So correct answer is A. This is relatively a new question, but you can easily crack this question. An elderly male, age 60 years, presented with left testicular swelling and ataxia. Here, this patient is having testicular swelling, so most probably the patient is having testicular tumor. And what is the most common testicular tumor in elderly males? So in elderly patients, the most common testicular tumor is lymphoma. Which type of lymphoma? It is non-Hodgkin's lymphoma. And what is the most common type of non-Hodgkin's lymphoma? DLBL, diffuse large B-cell lymphoma. So how will you explain this ataxia? See, the patients who are having malignancy or patients who are having tumor, those patients are having paraneoplastic neurological disorders. And in this paraneoplastic neurological disorders, what happens? There is cerebellar degeneration. What's that? Cerebellar degeneration. And this cerebellar degeneration can lead to ataxia. So it is seen that patients who are having testicular tumor, there is paraneoplastic neurological disorder leading to cerebellar degeneration, and the symptom is ataxia. First, see what's written in Harrison. So related to cerebellar degeneration, what kind of paraneoplastic? It is written that patients develop dysarthria, gait and limb ataxia. In which tumors it can be seen? It can be seen in any tumor, right? But commonly it is seen in small cell lung cancer, cancer of breast and ovary, Hodgkin's lymphoma, right? So if you see the option, let me tell you, germ cell tumor is relatively uncommon in elderly patients, and germ cell tumors are rarely responsible for cerebellar degeneration. Clear? Glioblastoma multiforme, you cannot explain the testicular swelling. Non-Hodgkin's lymphoma, Hodgkin's lymphoma. Hodgkin's lymphoma can lead to cerebellar degeneration, but Hodgkin's lymphoma is a tumor of lymphatics, so it cannot be seen generally in testis. So if you see the age, if you see the symptom, correct answer for this question is C, that is non-Hodgkin's lymphoma. So what is the cause of ataxia? It is paraneoplastic neurological disorder caused by cerebellar degeneration. So correct answer for this question is C. See the question number 17. A patient had chest trauma whose chest X-ray image is given below. Which of the following procedure is contraindicated? So tell me, what are the findings of this chest X-ray? See on the left side, in the lower half, what you can see on the left hemithorax, in the lower half there is large gastric air bubble. So this is, there is presence of large gastric air bubble. Simultaneously, what else you can see? That there is left lower zone atelectasis. And what else? You can see that there is pleural effusion. So there is pleural effusion, left lower zone atelectasis, and in the lower half of left hemithorax there is presence of gastric air bubble after trauma. So what happened actually? After trauma there is diaphragmatic rupture, and because of that rupture there is herniation of stomach into the left hemithorax. So this is actually traumatic diaphragmatic hernia. It's a case of traumatic diaphragmatic hernia. And if it's a case of traumatic diaphragmatic hernia, what will happen if you are going to insert the chest tube? Actually, there was one interesting story. One of our first year PG, means first year resident, who was very enthusiastic to perform the procedures. You know, in first year PG, the residents are performing venous cut down, they insert chest tube. So he was over enthusiastic. One patient presented to emergency and he was having some respiratory complaint. He was having chest x-ray also in the hand. He saw the x-ray and he was not a very experienced. So actually it was a case of traumatic diaphragmatic hernia. And when he saw the x-ray, the first year PG was thinking that, okay, it must be a case of pneumothorax. Let me insert the chest tube. So he took the patient to minor OT and he inserted the chest tube. The moment he inserted the chest tube, what happened? Yes, fecal matter started coming out. You tell me what's the diagnosis? So on insertion of chest tube, fecal matter started coming out. So obviously it's a diaphragmatic hernia. You tell me which component was herniated. Actually, it was transverse colon. Can you see here? So it was the transverse colon and he inserted the ICD in transverse colon. Fecal matter started coming out. So you know that diaphragmatic hernia is a contraindication for ICD insertion. Clear? So if you are going to manage this patient, is a patient of traumatic diaphragmatic hernia, we perform the surgery. We reduce the content, we repair the defect, and after repairing the defect, we insert the chest tube. So in diaphragmatic hernia, insertion of ICD preoperatively is contraindicated. Clear? So see the question again. Since on the basis of this X-ray, you found that patient is having traumatic diaphragmatic hernia, you can go for log roll, nasogastric tube can be inserted, you can give epidural anesthesia. But intercostal drain insertion, chest tube insertion, it's contraindicated. So correct answer for this question is B. See the question number 18. Patient presented to the hospital after penetrating trauma. What kind of trauma? Knife injury over arm. So there was knife injury over arm. Radial and ulnar pulses were not felt. And see, right brachial artery has 2.5 centimeter longitudinal cut. Ideal repair. Now see, suppose this is the brachial artery. And if this artery is having some kind of cut like this, yes, and without any gap, we can go for end-to-end repair. So any vascular injury, arterial injury, if you can perform end-to-end anastomosis, you should go for the end-to-end anastomosis. If it's not possible, why? Because the length of injury is longer. So if end-to-end anastomosis cannot be done, we should go for the interposition graft. Interposition graft means you should use a graft in between these segments. So this is interposition graft where the injury occurred. Now which kind of graft should be used? We have two grafts. One is natural vascular graft and the most commonly used is great saphenous vein or long saphenous vein, and the second is prosthetic graft. What is the problem with prosthetic graft? If a large vessel is injured like aorta, iliac artery, you can use prosthetic graft because you don't have any natural vascular graft for that. But whenever the smaller arteries of arm or of leg is involved, for such cases, the great saphenous vein is an ideal graft. So why this long saphenous vein or great saphenous vein is ideal? Because of its elastic property. So it is compliant with pulsation of artery. Second, adequate size match. So almost the size is approximate to brachial artery. It is non-thrombogenic. What is the problem with prosthetic grafts? They are thrombogenic. And if you compare the patency of long saphenous vein over the prosthetic grafts for smaller arteries, this is superior. So because of elastic property, adequate size match, it is non-thrombogenic, and because of superior long-term patency, which graft is preferred? So for this interposition, we prefer long saphenous or great saphenous vein. So what is the ideal repair? Primary closure with saphenous vein patch. No, you should not use the patch. The whole vein is used as interposition graft. Repair with prosthetic graft, we can do that. Ligate the artery, no. Repair with saphenous vein graft. Out of these two, which one is better option? So D. Saphenous vein graft is preferred over prosthetic graft for smaller arteries. So arteries, arterial injury of arm or leg, we prefer long saphenous vein. So correct answer for this question is D. See what's written in subiston. Vessel injury that cannot be repaired by primary end-to-end technique will require an interposition graft. And what is the most desirable graft? Autologous great saphenous vein. So it is patient's great saphenous vein, And from which side we are supposed to harvest it? You should harvest it from uninjured leg. So why it is preferred? We discussed because of elastic properties. It is compliant with normal pulsatile flow of an artery. It is having adequate size match for graft, and it's non-thrombogenic, superior long-term patency. So in which cases you use the prosthetic graft? Whenever it is not available. Why? Because it was already harvested, or in the trauma it is injured, or sometimes whenever there is size mismatch. In that case you can use the prosthetic graft, but the preferred one is long saphenous vein. So correct answer for this question is repair with saphenous vein graft. From the last 2 to 3 years, continuously similar questions were asked many times. A patient suffered tibia fracture. So first there is fracture a month ago. Now his cast was removed. There was some ecchymosis on the skin. 5 days later he came with pain on lifting his great toe. So on lifting the great toe he is having pain and decreased sensation in the first web space. Clear? So pain on passive movement. Clear? Or pain on the movement. There is posterior tibial and dorsalis pedis pulses were felt. So pulsations were felt. What will be the next step? Now, if a patient is having fracture of tibia or any fracture, especially in the lower limb, followed by excessive pain or pain on the passive stretching, patient is having paresthesia, all these findings are suggestive of what? Compartment syndrome. You know, pulselessness is a late sign and paralysis is having worse prognosis. In relation to compartment syndrome, pulselessness is a late sign and paralysis, it is having worst prognosis. So you know this patient is having compartment syndrome. Generally you can diagnose the patient on the basis of clinical finding itself, but whenever there is some confusion, or imagine a patient is intubated, a patient is having head injury, in such cases you have to document the increased pressure in the compartment, and how much should be the pressure? More than 30 mmHg. So if in the compartment the pressure is more than 30 mmHg, diagnosis is confirmed. So how you do it? Not by Doppler. Measure anterior compartment pressure, test related to DIC, admit and give analgesic and antibiotics. No, whenever the diagnosis of compartment syndrome is established, we have to perform fasciotomy. Longitudinal fasciotomy is done bilaterally. So correct answer for this question is B. So see what's written in Bailey related to compartment syndrome. In majority of cases, what's the most common cause? Yes, it's the fracture. In how many cases? 70%. And generally it's a clinical diagnosis. There is pain out of proportion, increasing pain, and pain on passive stretching. Paralysis, paresthesia, pallor, these are late sign. And what is extremely late sign? It is pulselessness. So how you are going to measure the pressure? We have to insert a catheter and it is attached to compartment pressure monitor. So here you can see this is the anterior compartment. You inserted the catheter and this catheter is attached to this monitor here. The reading is displayed. So you can see the reading of pressure, and if it is more than 30 mmHg, diagnosis is confirmed and we have to perform what? Longitudinal fasciotomy, and it is done bilaterally. So correct answer for this question is B. Question number 20 is a repeat question. It was asked in AIIMS. Nasogastric tube length is measured by. So how we measure? From nose, tip of nose to ear lobule to xiphoid process. So NEX. So you can see this is nose, this is ear lobule, and this is what? Xiphoid process. So nose, ear lobule, xiphoid process. So NEX, this is how we measure the nasogastric tube length. So it's a tip of nose to ear lobule and xiphoid process. Correct answer is A. From last 2-3 years, there is one question almost every year in each and every paper related to cannula. Yes. So patient was brought into emergency department. Intern was asked about flow rate, per minute of cannula shown. So this is green cannula. And how much is the flow rate of green cannula? This is 90 ml per minute. How much? It's the 90 ml per minute. So which option you are going to choose? Closest one is 86. So correct answer for this question is B. Cannula color coding is size is very important. So see, orange cannula is of 14 gauge, gray is 16, green 18, most commonly asked, pink most commonly asked 20. So green is of 18 gauge, pink is 20, blue 22, yellow 24, violet 26. How to remember? Mnemonic is organize green pink by violet. Okay, so OR, that is orange, this is 14 gauge, G, that is gray, 16 gauge, green, it is 18 gauge, pink is 20, B, that's blue, and blue is 22, yellow, that's 24, and violet, this is 26. So you can easily remember the sizes. Now see the flow rate. So orange having maximum flow rate of 240 ml per minute. These four you are supposed to remember because these are commonly used cannulas, right? So for gray it is 180 and it's in green it is 90 ml per minute. Clear? For pink it is 60 ml per minute and for blue this is 36 ml per minute. For yellow cannula it is 20 ml per minute and for violet it is 13 ml per minute. See the question number 22. Which phase of cell cycle is least radiosensitive, means which is radioresistant? So the most radiosensitive, this is most radiosensitive, it is G2, and least radiosensitive, that is S phase. So S phase is radioresistant and the most radiosensitive is G2. So correct answer for this question is B. There are many questions asked related to radiosensitivity of cell cycle, phases of cell cycle. So the most sensitive to radiation is G2M phase followed by G2. If G2M is there in the option, choose G2M. If it is not there, choose G2. And most resistant to radiation, that is S phase. In S phase, it's the end of S phase which is most resistant. Now, because of radiation exposure, there are two problems. One is chromosomal aberration and the second is chromatid aberration. So in G1 phase, radiation exposure leads to chromosomal aberration, and in G2 phase, it leads to chromatid aberration. Okay. So if we see the susceptibility of various phases of cell cycle to radiation, it's G2M followed by G2 followed by M followed by G1 followed by early S phase followed by late S phase. So overall, if all these options are there, most radiosensitive G2M followed by G2, least radiosensitive is S phase, which is late S phase. So these were the 22 questions of INI-CET November 2021. So I hope you enjoyed this discussion session. Good luck.